The Genuine Article. Discussion and commentary based on articles from JACC.
Hello, I'm Tony DeMaria, the editor of JACC, here with Inside JACC, and today I'm talking to Dr. Donald Lloyd-Jones, and Dr. Lloyd-Jones is the chair of the Department of Preventive Medicine at Northwestern and the senior author on an important paper about to be published in JACC that deals with the relationship of coronary artery calcium scores to Framingham risk factor in the very renowned MESA, multi-ethnic study of atherosclerosis study. And in this study, Dr. Lloyd-Jones and his colleagues were particularly interested not only in the relationship of the degree of coronary artery calcification to Framingham risk score, but particularly the value of coronary calcium screening in patients in the very low risk and low risk Framingham categories. And what they found was that the incidence of coronary artery calcification was really quite low in both of the low risk categories, approximately 2% and 5% respectively, in under 2.5% and under 5%. And so they concluded that there was clearly a relationship between coronary calcification and 10-year risk as adjudicated by Framingham, but that in the very low risk category, coronary artery calcification probably did not add significantly. Now, perhaps, Dr. Lloyd-Jones, you might review for us what distinguishes the very low risk from the low risk in Framingham?
I think it's been widely appreciated that the presence of coronary calcification, and particularly a very high coronary calcium score, greater than 300 or greater than 400, is associated with substantial excess risk for having a coronary event, even among people who may have a low predicted Framingham risk. But what hasn't really been done is to understand the prevalence of that high coronary calcium score in a community-based sample, such as the MESA cohort, and to understand how many people we would need to screen among a community-based cohort in order to find that one individual with a very high coronary calcium score.
Now, why did you pick a calcium score of 300?
Well, I think that the literature would say most people have selected either 400 or 300 as, as a threshold for a very high-risk individual. We just didn't have all that many people who had a score above 400, but 300 has been shown in MESA and in other cohorts to also indicate an individual who's at least 7 times higher risk than someone who has no coronary calcium. So we went with that threshold in our study.
Now, I assume that all of us are going to apply every preventive measure to our patients. We're going to control their blood pressure and stop them from smoking and maintain optimal risk, etc. So I guess the coronary calcium scanning applies primarily to statin therapy, or let's say lipid lowering. Is that your idea?
I think that's right. Although, as you know, in the current framework, what we do is we estimate the risk using the Framingham variables and a risk score like Framingham, and then we're often left with a bit of a conundrum. We have an individual who, may have a low 10-year predicted risk, but nonetheless has a lot of features, perhaps a family history or a cholesterol that's far from optimal, where we might choose to treat that individual if we had more information. And I think that's where subclinical disease imaging, is trying to find a niche, or we're trying to understand better whether it might be the clue we need to help refine our risk estimates a little bit further.
So based upon your study, who should have coronary artery calcium screening at the moment?
Mm-hmm. Well, so what we found was that if you have a predicted Framingham risk of less than 5% for an event in the next 10 years, you would need to screen somewhere between 25 and 60 people just to find an individual with a high coronary calcium score. And to us, that doesn't seem like a very good yield proposition, and probably is not going to be cost effective. But above a Framingham predicted risk of 5%, now you're talking about screening only about 5 to 10 individuals to find one who has a very high coronary calcium score. And that may well be the kind of range where screening would make a lot more sense.
Very useful information. Thanks a million for being with us. For Inside Jack, I'm Tony DeMaria.